I have 2 jobs and 3 kids, and my mom needs a lot of help these days too. So, yeah, my life is busy and complicated. And I wish healthcare could be uncomplicated because I don't have the time or the energy or, quite frankly, the patience to figure it out. It shouldn't be so hard to manage my records or so tough to get in touch with my doctors, right? Why is there always another step when I just really want an answer?
I'm a clinician, but sometimes I feel like a data entry clerk these days. I know it's part of the job, but I want to focus on my patients. That's the important part. That's why I spent all those years in school, to help with their health, their problems, their lives. So, if you ask me, it's time we get computers that make the job easier. No more awkward interfaces or hours spent searching through useless information. No more anything that gets between me and my patients.
I'm a data scientist, and recently I co-founded a company. Now, our mission is to foster healthcare knowledge discovery. It should be great, and I think it will be, just eventually. The thing is, I've done this before in both the financial and communication sectors, but it is harder this time around between all of the regulations around using healthcare data and the massive fragmentation within the system itself. Look, we can't get our hands on the data we need to validate and prove our concept. So we're struggling to move forward, and we're left wondering why there's so much stopping us.
I've spent my entire career in health services administration for both providers and insurers. I think this recent trend of measuring and paying for value, yeah, it's encouraging. But honestly, it's frustrating too. Hey, there's incentive to collaborate, which should be good for everyone. But that's creating new data demands that are tough to fulfill. We struggle to get the data we need. We struggle with our partners' prioritization. We struggle with our legal department to get data sharing agreements, and not to mention the spreadsheets. 1 million spreadsheets to make sense of anything. Just sometimes it seems like our whole health economy is designed to keep us from collaborating.
Look, improving the health and welfare of our citizens is a key public policy initiative for our government. But it's increasingly difficult to manage costs as our population ages and the number of long-term chronic conditions rises. And every single day, a physical and mental illness is a hit to our economy. I wish I could tell you where we should invest, but the disconnected nature of the healthcare system makes it impossible to know. I try to see patterns. I find missed opportunities, question marks. Digital health should be the answer. Maybe it still can be. There's a lot of obstacles to overcome before we get there.
You know, Chris, the obstacles we heard about are different in every country around the world, but they're very real. Patients can't get care, clinicians get frustrated and leave the business. We have trouble training up the next workforce so that there are clinician shortages projected around the world where they aren't already in existence. We have trouble getting research done. It's huge. It's really frustrating.
But it isn't all bad news. In fact, in the last 100 years, life expectancy has increased 100%.
Yeah, and you know, healthcare is now contributing about 10% of our global economy.
And interestingly, in 2003, it cost over $2.7 billion to sequence the human genome. Today, you can do that for less than $1,000.
And we're getting a heck of a lot more data to work with. You know, if we've been able to do all this with all those walls in place, think of what we might be able to do if the walls came down, if the walls didn't matter any longer. We want to spend the next few minutes talking about how you, how we, how other partners that we work with around the world are creating a future of care where the walls don't matter. And we like to call that vision Healthcare Unbounded.
Here in the Territory we have a large landmass, 1.3 million square kilometres, small population, 230 odd thousand, a very large portion of which live out remotely in Aboriginal communities out in the bush, long way from generally essential services. Is it a traditional EMR? No, hell no. You can go and find one of those in a big urban hospital somewhere. This is very different. This is a single digital tool for our clinicians right across the jurisdiction, right across every element of clinical care. The litmus test for us is it won't matter if you're a nurse in a remote Aboriginal clinic logging in to treat a patient who presents at the clinic, or you're in the intensive care ward at Royal Darwin Hospital. You will access the same patient record in real time at your fingertips each and every time, and you'll be able to see what care has been provided in all of those other care settings.
What I think is really exciting about the Northern Territory is we're able to solve some very specific problems, but also solve them in a way that's meaningful in other parts of the world and other environments. For example, some of these remote clinics don't have a full-time care provider, often don't have reliable internet connections. So we've built what we call TrakCare Remote, which is an offline mode of TrakCare where you can download a cohort of patients to a laptop, bring that laptop out to the remote community. From there, you're using TrakCare and you bring that laptop back to the central hospital, and that record then gets merged in with the central record.
One of the significant challenges we have for our Indigenous population is the incidence of chronic disease. And what's so important here is most of those health conditions are preventable. If we can coordinate our care better, if we can get on the front foot earlier, if we can be more proactive in our delivery of care and services, people shouldn't get so sick.
The population moves around a lot. It's difficult to have set appointments. So a lot of their care is based on care plans and recall lists. And it's very opportunistic. So if somebody comes in for an appointment and they bring a relative, you might take that opportunity to treat the relative while they're there, vaccinate the kids, that sort of thing. And so we're doing some work on the product, and a lot of that work is, I think, applicable where a traditional model of come back and see me in 6 weeks, it isn't really a meaningful way of working with a patient.
InterSystems listened and took the trouble to seek to understand the challenge of delivering healthcare here in the Northern Territory, and they're still listening, and we're working together and it's a terrible cliche, but it's working as a partnership, not just a commercial arrangement. I'm someone who's grown up here in the Territory. My kids have been born here. I'll see my time out here, and I think it's important to me that we leave something behind that's better than what's there today. So if we're sitting here in 20 years' time and we're seeing an improvement in those health outcomes, particularly for our most vulnerable, our Territorians who've got the poorest health now, then that looks like success to me.
And in another story, a friend of mine, Kathy, told me about her father who had had a stroke and had an implanted ECG device. And that's not unusual. That does happen these days. But what was unusual is Dad had an appointment with the doctor the next day. And the family was just absolutely baffled because none of them had made the appointment, nor had Dad made the appointment. So it turned out that he'd had a minor incident. The device sent a notification to the doctor who said, I think we need to see this guy. And Dad was seen, all worked out, and here technology did some things you wouldn't even have expected long ago. So the walls of the hospital are no longer the only place where you can get care. You have ICUs oftentimes being replaced by remote ICUs. You have surgery sometimes being done from afar. You've got patients going home with devices that are implanted instead of tethered. And what I want to share with you now is one of our partners, the Rhodes Group, has tackled healthcare unbounded in the world of the laboratory, and I'll let them speak.
You know, laboratories are under extreme pressure, primarily from federal regulation, that is stripping away their ability to charge cost per test. It's reducing the cost that they can charge and bringing it in line primarily in the Medicaid space. And these changes are causing laboratories to have to find new ways to provide those services, to drive their revenue, to remain healthy. And so there's a lot of change in the laboratory environment at this time. At the Rhodes Group, we develop software for use by laboratories all over the world. In short, we're helping labs go beyond the walls of the hospital to break down the walls of care.
Using InterSystems Iris for Health, we developed a novel software product called eMyLab Collect. It's a great tool that assists hospital phlebotomists as well as mobile technicians collecting samples on the road by streaming specimen collection and tracking workflow.
Once I've fired up my eLab Collect app, all my patients are listed with what specimens need to be drawn. With all my patients' information here, I can identify them and draw them whether I'm at the bedside in a hospital, in my patient's home, or at a long-term care facility. I can verify my patients no matter where I am.
A lot of laboratories are still using handwritten labels. You can imagine the risk of errors involved in that. Using eMyLab Collect, a technician can instead print out an instrument-ready label that's barcoded for the lab and the instrument it's destined for. For the eMyLab Collect project, the InterSystems Iris for Health gave us exactly the flexibility we needed. eMyLab Collect talks to a lot of different sources, all built on HL7. With the Health Connect component of eMyLab Collect, we can do that transformation, we can do the transportation of the data, and we can load the database. So it made it simple for our team. The fact that I can use standard SQL communications to the database meant my developers didn't have to learn a new database language, so it was easy.
You know, InterSystems is such a significant player in the healthcare market. And what they do on the back-end technology from an efficiency and operational support aspect, for Rhodes it's a significant benefit to build on that and to create our new product lines using the InterSystem technologies.
All those enhancements are great, but every enhancement creates new challenges. So as care can be delivered anywhere, and as we document new data sources, we have the challenge that we can end up with a fragmented system and a disconnected system and an uncoordinated care experience for patients. So we need to be able to ensure that we have a unified view of that information. We have to be able to take all those new data formats Chris talked about and all the data sources, whether they're insurers, whether they're providers, whether they're social care agencies, whether they're the patients themselves, including TrakCare, and we need to use it to create a comprehensive longitudinal view of the information that lets caregivers deliver a world-class care experience because they know what happened before they saw the patient. They can document their care and manage it, and they know what happens as an outcome later. And patients and their families are also able to manage their care effectively, but perhaps more importantly, they can communicate well with their providers, and they can build long-term relationships with those providers. So we have an example of a customer in London, a group called Coordinate My Care, and they've created a patient-centric experience for serious illness. It's part of the Royal Marsden Cancer Hospital. So I'd like to let them share what they're doing as we move forward.
Coordinate My Care in London uses shared care plans to help create a coordinated, personalised care experience for those with serious illness. Professor Julia Riley, consultant in palliative medicine at the Royal Marsden Hospital, explains.
Coordinate My Care started as a result of my own sister-in-law, who, when she was 32, had a malignant melanoma and was told she had less than 6 months to live. And during that time, She was at home with 4 tiny children under the age of 5, and she had a care plan from the district nurse, from the GP, from 2 hospitals, and from the community services. And yet when she called for help, all the plans were different. When she died, a group of consultants across London got together and we decided to do a paper version of having the same plan. And that became the digital plan, and then the next step was to have that plan linked to all the urgent care services. And so we now have Coordinate My Care, which is an urgent care plan which can be accessed all over London.
Recently married Lisa is coming to terms with her terminal illness.
Lisa, you know all about your plan. Tell me what your plan means to you.
Okay, it needs to express what I want in terms of my care, both immediate and long term, and for end of life. It needs to describe me. That's what I want from a CMC. I had a recent hospital stay and was admitted to the Royal Marsden in Chelsea, where nurse teams informed me about the CMC plan. Initial impressions were, what a fantastic idea. I don't want to have to keep repeating my story. I found that I had to keep repeating to every single person that I saw my background history, where I was at that particular point in time. And for someone with my condition at the moment, that's exhausting. It really is tiring.
With the help of software from InterSystems, CMC has continued to evolve since its inception as a paper-based system. The latest edition is My CMC.
Patients have now said they want to take control and they want to be able to start their own plans. My CMC is the new front door to CMC. My CMC is live, so the services across London, anyone with a London postcode can go online and create their own My CMC plan.
My CMC empowers patients when they're at their most vulnerable. Lisa says it best.
I don't need to tell any of the healthcare professionals what to do. It should be written in my plan that they know and they're expecting me and what's going to happen.
By the way, a lot of the groundbreaking work on which CMC's whole model of care is based came out of this region. It came out of work done in Australia originally. They did all of what they've been able to do by really envisioning and creating a whole new type of data, a shared care plan. A care plan not of traditional what orders do I have in an event of an emergency, but of a description of what the patient valued and what mattered to them and how to interact with them as an individual. But they also created new data sources, including the patients themselves. They married that to traditional information sources from all the EMRs across London. They integrate with all kinds of them, and sharing that information out. But one of the things that they did was not just influence the care of individuals, but they're leveraging that data to understand how they can do better. So all that information that they've poured into that unified care record to help manage end-of-life care for you or you or you is used to help them identify best practices. So they'll mine that data to see which organizations are, in fact, leveraging that care plan the most, which ones are keeping it up to date, which ones are, in fact, having their patients' wishes followed. And they use that to identify best practice and then to help train other organizations, other parts of the care system around London to improve the process on a continuous basis. They've also been using data around adoption from the beginning, and they measure data around outcomes. For example, they know that 79% of the patients who pass away in London with a CMC care plan in place, in fact, die in the setting, the care setting that they have asked and prefer. And that contrasts incredibly with the rate across the English population as a whole. They use the information that they've gathered then to help them with funding requests, to help generate support at the government level, and to help create support to expand the service across other parts of England. So that data becomes critical to them, not just at the individual level, but across the organization. And that's what we're seeing more and more as people look at what kinds of problems do they want us to help with. More and more they're saying, we really need that information to help us understand our organizations and improve what we're doing. So they're looking for us to help them acquire data in all formats and then validate the quality of that data, normalize it, because as we know, data that comes from different sources usually uses different code sets, maybe in different formats, maybe structured, unstructured. How do we normalize that and make it useful and meaningful? How can we operate on it and on analytics? Sometimes they want us to enrich that data with new code sets or using it to create new individual types of data. They're asking us to bring that together and then serve it up through FHIR, serve it up through other APIs so that they can use it to manage their own organizations, discover new information, and predict where they want to go in the future. And they're using that to help develop new intelligent workflows and systems, which Chris will talk about now.
We have now moved from collecting a lot of data, sharing data, unifying data, and now we need to do something with all of this and have a smarter system, something that can work for the clinician and for the patient. In the early days, if any of us can remember back to then, there was no computer between the doctor and the clinician. They faced each other, they talked, they listened. Then we put a computer in the middle. And generally, the reason it was there was to document what they were not talking or sharing. So it looked like it was helping, but as Emily in our early slides said, it really was an obstruction. It prevented the patient and the clinician from being able to connect. Now what we need to do is think of the computer as something with a brain, something that can actually help us provide better care, do something better. One of our customers in Thailand is working with our partner HBI, and you're going to hear from both the customer and our partner this afternoon, looking through the data that they have in their EHR about their patients so that they can look and determine danger of sepsis, potential readmissions within 30 days, danger of immediate death. And this form of predictive analytics that uses machine learning is able to take that data that may be sitting there in this bit bucket and do something with it, help the clinicians change the way they are going to be treating a particular patient. This same hospital is using InterSystems text analytics to look through unstructured data and identify common concepts that they're seeing throughout the different charts. So this is obviously something that is a beginning for this particular hospital. Some of you may also be trying experiments like this, but I think we are understanding that collecting data and sharing data is just not enough anymore. One of the things that we tend to forget is the EHR is definitely critical to our existence in healthcare IT. It has lots of information, but it doesn't have everything. And some of the standards like FHIR are now being used to give you more power with the EHR. There in the US, a hospital, Vanderbilt Ingram Cancer Center, built an app that allowed them to access this wide body of knowledge about cancer and cancer treatments. And they hooked it up to their EHR so they can actually, when looking at a patient, access that database of knowledge, pull relevant information in, and make a decision. And if you think about it, that's a lot of data for someone to remember. In fact, it's impossible because there's too much and it changes daily. So this helps strengthen the power of the data that's in front of them to make decisions. So what if we could actually extend further out, not a one-to-one or looking at data knowledge, but we could actually network? Just recently, I don't know if any of you have seen it, but Netflix came up with a series called Diagnosis. And what they're doing is taking very difficult cases, those that really never were diagnosed, and they are looking at outsourcing, crowdsourcing a diagnosis. So they globally send information out about these cases in order to have people respond and provide information so that they are able to in some cases, disappointingly, they didn't get a diagnosis, but in many cases, they actually did. It's worth watching. It's kind of fun if you like medical stuff, which I assume you all do. And so what if we could harness that same power to keep everyone connected and working to a common care plan, one that also accounted for the patient wishes like we saw with CMC. My granddaughter, Emma, had a serious, rare condition. She had a series of medication regimens, many home therapies, and she saw lots of specialists, and none of them were connected. None of them talked to each other. The way her care was managed is my daughter had a stack of paper that she carried from one appointment to the next. The family's goal was to keep Emma out of the hospital, and that was stated pretty clearly. But every time Becca met a new doctor, she had to go through the whole litany again and explain it all. And ironically, the most powerful source of medical information came from a Facebook group of mothers who had children with similar conditions. And wouldn't it be something if we had a care plan that actually tapped into common, just places that had information that could help? You know, it wouldn't have changed anything, but it might have helped the doctors get a little education, and it might have lessened the burden on my family. So remember the story that I told just a little bit earlier about the ECG monitor? Whoops, don't want to do that. Don't want to. Okay.
Chris, one more. Click one more.
Which way? It looked good here. Imagine we have a doctor sitting at home in an evening. We have a patient who's in a conference in Thailand, and the patient starts to have some physical problems and contacts the doctor to say, my medications don't seem to be working. I mean, there are options. The doctor could contact a doctor here, they could go off to a hospital, but we have a partner, RxMX, who works with medication regimens so that the doctor logs the regimens for the patient, and this doctor could stay at home, look at the regimen, adjust it, and the patient could go about the conference activities, and the doctor could stay at home. So what if some of this could be done today? What if you were able to see systems talking to each other, working, tapping into things? I am really excited, and I mean it, truly mean it, to introduce my colleagues from Asia who have now got the opportunity to demonstrate our systems and systems working together. So welcome them to the stage.
Good morning, everyone. My name is Joe Wang. 2 days ago, I had a rash on my left hand. This morning, it's becoming more and more itching. So I decided to make an appointment with my family medicine doctor. I'm going to use the patient portal to request it.
Apple TV. It's not on the screen.
Okay. I'm going to open the patient portal, request appointment. The family medicine doctor is Kathleen. Primary care is a new concern. Rash for 2 days. This week is okay with me. Thursday morning? Yes, always call me when this has been done. Well, looks okay. I'm going to submit. So message has been sent to my doctor.
I'm Dr. Catherine Liu. I received a request from my patient, John Wang, this morning, saying that he had had rash for 2 days. I'm going to go through his medical history to see if there was anything similar happened. So I'm going to problem timeline and select the information that I need. There's nothing happened before, but I know that John has primary hypertension, and then he had an operation when he was younger. Furthermore, I can go to Clinical Viewer, where I can search the patient information in full network, including the data that was even collected in other healthcare organizations. For example, I can see that there is a record of allergy of fish. This might be related to his rash. Again, I can also see his previous lab results. So now I have a comprehensive view of my patient, but I believe that I need to call him before I move forward to the next step. So I'm calling John via Skype. Hi, John.
Hi, doctor.
Hi, I received a request from you. Is there anything that I can help?
Yes, it's a rash. It has been 2 days.
Oh, can I see your rash, please?
Yes.
Oh.
You see the red bumps? It's
Yes.
very itching.
Oh, it seems quite severe. I suggest you coming to the hospital for further investigations.
Okay.
I will ask the nurse to make an appointment for you, so I will see you later today, okay?
No problem.
See you, bye-bye.
See you, doctor.
Good morning, everyone. I'm the nurse. So the appointment has been made to the system, and the booking is confirmed. Now, the patient is arrived at the hospital. He is doing his self-monitoring with this device. The data from this device is captured into the system, which allows me to see in the system. And now he is arrived to the clinic in front of me at the counter. Good morning.
Good morning.
What can I help you?
My name is Joe Wang. I have an appointment booking with Dr. Kathleen Liu this morning.
All right. Can I see your hospital number, please?
How about this QR code?
Oh, sure. I can scan your QR. All right. You are Mr. John Wang.
Yes.
Okay, and I can see that you are the same one in the picture.
Mhm,
Okay.
yeah. Yes.
Can I have your birth date, please?
August 1st, 1987.
Okay, it says that you had a rash for 2 days.
Yes.
Okay, then I will record that you have arrived at the clinic.
Okay.
Okay, let me record a little bit more about yourself before I send you to the doctor.
Sure.
Okay, now let me go to your record. I can see that you've done the vital sign record already.
Yes.
Oh, okay, I will attach it into my
As a machine, yes.
Yeah. And can I take a picture of your hand, please?
Yeah, it's very itching, you see. Yes, very itching.
Stop scratch.
Okay.
Thank you. Okay, I will record that this is the hand rash. And this is the patient photo. All right, okay, everything is good to go. Please go to see the doctor. She's waiting for you.
Okay. Hi, doctor.
Hi, John. Hi, so you are coming today for the rash, right?
Yes.
Okay, so I'm going to record your recent phone encounter first. Patient came to the hospital due to rash. Full stop. Okay, so I've recorded your recent phone encounter, and I can see that your vital signs, the picture of your rash, have been recorded in the system.
Okay.
I believe you are allergic to something, so I'm going to prescribe some medications for you.
All right.
Well, the medication is called Zyrtec. You only take 1 tablet per day for 7 days, and I will make a follow-up visit for you.
No problem.
Furthermore, you need to do some additional tests, which is allergen tests. I will receive an alert after the result is ready, and you can also review your lab results via your patient portal.
Okay, fantastic.
Okay? Anything else that I can help you?
No,
Okay.
very clear. Okay.
So, have a good day.
Have a good day.
Bye-bye.
Bye-bye.
I want to be sure I don't shake hands with him. It's hard to develop smart systems if we have holes in our information. So we need to be able to see the big picture, or we're going to draw wrong conclusions. When we don't have enough density to our data, things may look different than they do when we have the whole picture. I talked earlier about the need to expand and unify data across boundaries, and I wanted to amplify a little more on organizations that are doing that and why they're doing it. More and more people are asking us to help with this, and we think of it as creating a pipeline of information. In fact, if you think about the 20th century and a lot of the advances that we made in public health, they were driven by clean water. If we look forward for the 21st century at the things we want to accomplish and all the promise we have, it's really about digital health. And so as public health depended on clean water, digital health is going to depend on clean data and a clean data pipeline. And when we have that pipeline in place, we can do all kinds of things. With even a narrow set of information, we can use reports and dashboards to help us measure performance and improve it. So organizations like Providence St. Joseph Health in Southern California, and actually they're based in Southern California for the group we work with, but they extend up through all of California into Texas, into New Mexico, and they bring together a data pipeline that they then use to help them manage the reimbursement they're going to get from their payers. In the US, as we move to value-based care, the idea is to have pay for performance. So you're not going to earn your full reimbursement. You're not going to get the payment you're counting on if you don't perform at a certain level on certain quality measures. The problem is you don't get the results of those measures until the end of the year, after it's too late to do anything about them. So what they're doing is they're leveraging that data pipeline they've created to build real-time dashboards that they can monitor throughout the year to say, are we in fact managing our diabetic population? And not just at the one site they're seeing, but across that whole region, because certain parts of that care, a foot exam or an eye exam or a blood test may occur somewhere else. Are we managing our hypertensive population? Are we in fact on track not only to have good health for the patients we're treating, but also to ensure we have good financial health for the organization? If we expand out that pipeline, make it a little wider, add in data from both clinical systems and insurers, add in data from social care agencies, we can help to manage and improve the health of an entire population. So if you look at groups like Greater Houston Health Connect, Houston is the 3rd largest city in the US, and they've created a data pipeline across that whole health ecosystem there. Or you look at groups like Healthix and their new merger partner, New York Care Information Gateway in New York City. They're leveraging a wide pipeline to bring together and create a unified record across their regions to improve population health management as a whole. And so they're doing that in real time using alerts and notifications. So a patient who's discharged from hospital, they would notify their primary care provider, who can then make sure that that transition happens smoothly and the patient is not at risk of readmission. Or a patient with a behavioral health problem who ends up in the emergency room, or for example in Rikers Island Prison in New York City, they can send a notification to their care manager so that they can intervene and get them back into a treatment plan. But they're not just looking at how they can use real-time notifications for individuals, They're looking at risk stratification across those populations. And they're working with people like HBI to do that risk stratification that lets them say, not only is the patient in front of me at risk, but I have an entire geographic region where I seem to be dealing with a lot of hypertensives who need treatment. Maybe I need to set up a community health clinic. Maybe I need to set up a new care management program. Do I need to enroll a group of patients? With a good data pipeline that's leveraged through APIs and through FHIR, you can build out new solutions. So organizations like Northwell Health are able to leverage data to enhance the identification of patients for clinical trials. Northwell's been building out a unified care record for a number of years. They have billions of data points at this stage. They keep increasing the number of data elements they're bringing in through devices. What they've started to do is to say, we really want to be able to automate the process of identifying candidates for clinical trials, and we want to harness the unstructured data in that record to do that. And so they've built in they're using APIs to leverage that. They've built in logic around that, and it's helping them in 3 ways. First of all, they're an academic teaching facility, so their own faculty are looking to be able to leverage that, the patients, and bring them into studies they're conducting. Secondly, it's helping them to monetize their data asset because they're able to get data from pharmaceutical companies for enrolling patients in clinical trials. And most importantly, they're giving their patients more options and better hope. Companies like HBI, who you'll hear about in a little while, are using massive amounts of data to build out new predictive analytics and new predictive models, and neural networks, and smarter solutions like Chris talked about. And finally, if you think about AI, if you think about precision medicine, it's about building models. The trouble is the model building is, in some ways, the easy part. The hard part is acquiring all the data to go into that model. In fact, it's about 80 to 95% of the effort for a data scientist. So what they're looking for is, can we create an ongoing stream of clean data that we can feed into these models? And companies like Concerto Health AI are taking that and saying, okay, we can build a model for a payer to more effectively evaluate whether a new treatment is cost effective and we want to pay for it, to help pharma companies more precisely target how a drug is going to affect a patient with a particular cancer and on a whole other set of conditions, to help CROs run those clinical trials more effectively. So we're seeing all kinds of uses for this clean data pipeline that we think are driving the kinds of digital health we all want to leverage. And we think that is going to let us all create a future of care. So what is it going to take to do that? How do we create an innovation environment that works? And that works for you, and it also works for us, frankly. Can we use data more effectively to find clinical guidelines and new clinical processes? Can we use it to create new, smarter medical devices? Can we use it to take the administrative cost out of the system so that we can redirect funds to patient care so that we can improve the bottom line of our organizations and fund our mission? We believe that we can do that, and it starts with brilliant ideas. You've all got brilliant ideas. We work with lots of brilliant people around the world, but you can't just make change happen with a good idea. You've got to have the tools to implement that idea. You've got to have the data we've already talked about today. But in healthcare, you've got to have something else. We heard from a guy, Jason, who was frustrated because he couldn't get his business going. Healthcare has a lot of regulatory constraints. As you cross boundaries, geographic boundaries, those rules change. We have to protect patient privacy. And that can create a lot of challenges as an entrepreneur tries to get going in a healthcare business. One of the organizations we work with is a group called Manifest Medics, They're the health information network, the largest health information network in California. California is the 5th largest economy in the world, just that one state in the US. And Manifest Medics is headed by a woman named Claudia Williams. Claudia worked for President Obama. She worked on health policy and innovation issues, and she used to meet regularly with entrepreneurs like our Jason a few minutes ago. And she'd fly out to Silicon Valley, and she'd meet with them, and they'd be very excited. And 18 months later, when she met with them again, she found them a lot less excited. They were getting a little discouraged because in order to validate their concept, in order to get their company off the ground, they had to partner with providers or with payer organizations. And they were spending all their time trying to negotiate the agreements to just use things. And those organizations had a primary mission of delivering healthcare, not working with entrepreneurs. So it was taking a long time, and 18 months later she'd go back, and they, at that point, would just barely have started getting data flowing. As she points out, 36 months into a startup, if you don't have any results, you've got a failed startup. So part of the mission that Manifest Medics has is to say, we want to remove the friction from the system. We want to create a shared health information utility that can be used by entrepreneurs, by data scientists, to in fact get their hands on the data to build relationships with provider organizations, with payer organizations. And so they've created a standard service so that once you have identified the information you need, you can build out that partnership, you can sign an agreement with them. That data can be provided rapidly in standard format. And they like to think of it as days. I suspect it's a little longer than that, but it sounds good when she tells it. There's another organization that we work with called TechSpring. TechSpring is an offshoot of Bay State Health, which recognized that they had a tremendous information asset, and they wanted to facilitate innovation in Western Massachusetts, the state where InterSystems is located. So Bay State created an offshoot to exactly form this kind of partnership, and we'll let you tell them about it. Let them tell you about it.
TechSpring is Bay State is TechSpring. We are pursuing the same charitable mission as Bay State Health. The mothership, at 12,500 person, $2.5 billion. TechSpring works with technology partners from very large companies like InterSystems down to earlier stage startups with people that have creative and strong potential solutions. Foundationally, the key problem in healthcare innovation is the access to healthcare. It's bringing the healthcare professionals and provider and payer organizations into the collaboration in an effective manner. We really are a front door to all of Bay State Health, and we leverage that as a living lab.
One of the things that our team does is bring care outside of the walls of the health system. A lot of the issues that our patients deal with, comorbidities, chronic diseases, they're the result of a lifestyle. So a lot of the big data that we're collecting enable us to look at how we can help people before they end up at that particular state. Ultimately, in order to bring a patient into the center of their care, it's necessary for us to go where they are. TechSpring offers, again, opportunities to be able to redefine the process for providing care at home, leveraging the technology that patients already have.
One of the important things that we've been working with InterSystems on is clinical trials to more easily do cohort identification, patient outreach, engage with the physicians. There are things that today are manual processes that are paper or in siloed systems where data doesn't flow, where the InterSystems platform can help us accelerate in that domain, and where we can help leverage the investments we already have.
Recently we did several projects that's worthwhile mentioning. So one is Apple, right? Apple and the Cerner, they want to build out the Apple Health record connection. And there's one important critical component, which is around the patient authentication. Bay State and TechSpring were able to support this type of validation, establish that connection, and was able to support the Apple Health Record integration for Cerner, for Baystate.
The only way we can get the efficiencies we need, the patient experience, the consumer experience, and the clinical innovation that's possible with predictive analytics and AI is by being really good at bringing technology into the process. Working at TechSpring and working with Baystate and with InterSystems, I get to be the facilitator between that world of patient care and then incredible technology and smart people and investment capital. That is what TechSpring is about, and that's what we're working on every day with partners like InterSystems.
We're doing a lot of work with TechSpring. One of the things we do is usability testing for Personal Community, our patient portal. They provide us a framework to do that. We prototype software there. We run focus groups with their insurance arm or with their care management team, with administrators and with clinicians to better understand the processes we want to solve for. And they're helping us with our innovation. Most recently, they're giving us large de-identified data sets on which we can experiment with machine learning, because we really want to tackle the challenge of those administrative costs I brought up a minute ago. How can we take administrative costs out of the system? How can we automate things for you so that you can devote your resources to care and to your financial health? So we've been working not only with TechSpring, but with Partners Healthcare in Boston and with Missouri Health Connection in the middle of the US, which is a large health information network. And we decided we wanted to tackle some low-hanging fruit. And one of those things is the challenge of patient matching. So when you're bringing data from multiple systems together, the question is John Smith over here the same as Jay Smith over here? And according to some of the studies in the US, and these are obviously local numbers, but if you have a mismatch and you try to join two records and it's an inpatient stay, it's about $2,000 a case in cost to undo the damage of that. If you have an emergency visit, it's about $800. So think about multiplying that out across your whole health system. It gets pretty pricey. So we wanted to know whether we could tackle some of the costs there. And one of those big costs is that if you are trying to resolve those two systems, you can use probabilistic matching to automate the process. We have a patient index system that does that. It's very good at it. But every time there's a question the machine can't resolve and isn't sure whether these two people are the same, you have to put it on the work list and you have to have a human being go through and work through that list. If we could take the human being out of more of those cases, we can bring down the cost of care. So we're really excited because when we did our initial machine learning tests, using some of the capabilities that we've now built into the Iris data platform, we've been able to cut that cost by about 47%. And so we're really excited about adding that to the Health Share Patient Index next year and looking for new ways we can leverage machine learning, leverage the partnerships we have with our customers to test those systems and make our own systems smarter and bring down the administrative overhead for you as you move forward adopting these systems. So we think innovation is pretty exciting. We think the things you're doing are pretty exciting, and we think they're going to do good things for our patients as we go forward.
My doctors are making things easier now. I don't have to take off work every time the kids seem sick. The care comes to me now.
I notice the difference every day. A lot of the administrative stuff that used to be a time suck just happens in the background now.
It just feels like there's nothing in the way of launching our first pilot.
For the first time, we and our partners are able to sit down at the table with a common set of information to work from.
There's a new outreach program we're very excited about. We're going to see more of our population getting to age right where they already live.
So that's it for us, and thank you for staying with us to hear about our vision for healthcare Unbounded. We really appreciate everything you all are doing also to help break down the walls in healthcare. I think working together, things can get better and better every year. And we look forward to seeing you here next year when we have our next InterSystems Asia-Pac meeting. So thank you for your attention.